Can you hear me now? You're muted, Ted.
Yeah, now I'm the problem. Okay. Well, very good. Let's see.
Okay.
I'm checking the time. We've got 12:02, so let's go ahead and get started. Hey, thanks.
Check it back.
Yep. Hey, thanks for coming to GM Insights, Georgia Memory Net's Insights program, outreach and education to all sorts of folks. We are super excited to have John Morgan here today. He is giving a talk on the practical aspects of care of patients with Parkinsonism. He's a professor of neurology at Augusta University, director of the Movement and Memory Disorder Program, director of MCG's Parkinson's Foundation Center of Excellence, and director of the Georgia Memory Net Memory Assessment Center. And I think that that's actually 2 sites now, so that's really great. We are so glad to have you here. I get to see you talk a lot during our case conferences, and I know that folks online today are in for a treat. So I'm going to turn it over to you, and there are some disclosures that you have. And
yeah, I'll show those in just a second.
Yep, not surprising given your level of expertise that people would want to consult with you. And John, I'll turn it over to you. Thanks, Dr. Morgan.
Great, thank you, Ted. Welcome, everyone. Thank you for joining us today for this talk on Parkinsonism and how to diagnose it and care for patients with it. I have 2 hats that I wear, as Ted mentioned. I do movement disorders. I've done that for about 20 years, and I've done memory for about 10 years. So I wear both hats in my clinical practice. These are my disclosures, which Ted mentioned, none of which are going to be discussed very relevantly to today's talk. And the objectives for the talk today are to discuss what is Parkinsonism. You may have heard the term, but what exactly does it mean? What are some of the important causes of Parkinsonism? And there are lots of them. And how can you use imaging of structural imaging with MRI and CAT scan, or functional imaging with DAT scan to help you in the differential diagnosis of patients with Parkinsonism? And how is Parkinsonism medically treated? That's a pretty simple answer for most folks, but it can get complicated. And what paramedical therapies are helpful to treat Parkinsonism? So the word Parkinson comes from James Parkinson. James Parkinson in 1817 wrote a paper, an essay on the shaking palsy. And you'll see in some old charts a billing code for paralysis agitans. So you're paralyzed and you can't move very well, but you're shaking and agitated. So that was named for years in medical billing for Parkinson's disease. And he luckily got most of his disease right. But I'll ask the audience, whoever is listening out there, can you tell me what he got wrong in this paragraph? Involuntary tremulous motion, so that means it's not a voluntary action, and you're tremoring, you're shaking, with lessened muscular power, so sometimes you can be stiff and slow in your muscles, especially on one side more than the other, and parts not in action, so at rest, and even when supported, with propensity for the trunk to bend forward and to pass from a walking to a running pace. So that's a classic thing that patients still complain about with their Parkinsonism in the clinic when they come in for a diagnosis of Parkinson's disease. Some of them may actually go from a walking to a running pace at times. And the senses and intellects being uninjured. What line is not correct?
Even when supported.
Actually, yeah, that is correct. So you typically, when your hand is at rest and supported, it doesn't shake as much, or it shakes more. With action, it improves when you do finger to nose and other activities. It's better. But what he got wrong was the senses and intellects being uninjured. So the senses of Parkinson's patients are injured. Their ability to distinguish hues of color is impaired, especially in the red-green variety. The sense of smell is impaired early in Parkinson's disease and doesn't respond much to levothyrope. And then even sense of taste has been, by biochemical means and fancy tests and stuff, has been shown to be reduced in patients with Parkinson's disease, but certainly not as much as the sense of smell has deteriorated. And then we do know that Parkinson's patients, the longer you live with Parkinson's disease, the more likely you are to develop impaired cognition and dementia even. So 77% in one study developed at least mild cognitive impairment or dementia over time. So what is Parkinsonism? Well, it's an umbrella term that is used to refer to conditions with similar movement-related effects, including slowness, rigidity, tremor, and gait disturbances, including postural instability as well. And so a combination of things that you may have some or parts of these, not all of them, in a given patient. Like an early patient with Parkinson's disease should not have a whole lot of postural instability or gait disturbance. So if you see that, you want to worry about other conditions besides Parkinson's, which we'll talk about in a second. So these are some videos from our practice over the years. I luckily have a very large video collection from our practice that we have, as well as from my former colleague, Dr. Sethi, Kapil Sethi, who's an international movement disorders expert and lectures even to this day on Parkinson's and other disorders. The lady in the first video, is about a 2-minute video, will show you lots of different features of Parkinson's in a relatively early to moderate kind of patient. Slowness, stiffness, resting tremor with her hands supported on her lap, and hunched posture, changes in gait, etc. So there's resting tremor in her right hand. So getting up from a seated position can be difficult sometimes with Parkinson's, but you got to get that nose over toes, as the therapist will tell you, to get up. And notice her right arm is folded and shaking as she gets up. It's not fully extended out. Notice she's shuffly somewhat when she walks, and her whole body moves as one unit. It turns as a whole unit versus twisting and leading with the trunk or that kind of thing. So notice the right arm is more flexed, tremulous motion in the hand, etc. And you would say that that walk is slower than normal. Her hands are supported on her lap, and she has asymmetric resting tremor. That's classic for Parkinson's disease. And with action, notice her tremor improved. It got better. That's classic as well. And sometimes it can reemerge. I don't know if her tremor does in this video at all, but you can hold it there for a while, and then the right hand will start shaking again with posture holding. That's rapidly altering movement testing, finger taps. And you commonly see decrement in the size of the finger taps and loss of the amplitude, and as the patient taps more. Notice the left side's a little better than the right. So asymmetry is classic. This is another rapid alternating movement showing Parkinson's bradykinesia. Not too bad. Faster with the left. Foot taps and other procedures you can do as well. Here's our foot taps, or heel taps. And then the patient in this video, let's see my cursor.
John, while you're teeing up that second video, is it the first patient that you showed us, she was holding her hand with the greater tremor in the other hand? Is that something that you often see, that patients are trying to still that hand or hide that tremor?
Absolutely, yeah. The classic Parkinsonian patient posture is to have it under their leg, sitting on it, or in their pocket, or this or that. I'll never forget, at church one day, I had a colleague that was working there, and I was like, what the heck is going on? And because I heard nothing but change jiggling the whole time. And he had Parkinson's disease and had his hand in his pocket jiggling all the change in his pocket. But yeah, hiding it is very classic for patients with Parkinson's. They tend to want to sit on it, move it, grip it, squeeze it, do things to reduce the tremor. And get those other videos to play. Oh, here we go. This is a nice guy that's in his 30s. He's very, shows you how bad bradykinesia can get. See those pauses or arrests in the movement? That's bradykinesia. And it's much worse on the left. He can barely maintain any amplitude and lots of pauses or arrests. Can you open and close your hand like that? Decrement of the amplitude, then pauses and arrests. That's bradykinesia. Much worse on the left. So despite people saying that there's not much asymmetry in Parkinson's mimics like MSA and PSP, there is. He doesn't swing his arms when he walks down the hallway. He has kind of a lurching type gait, turns multiple steps slowly. Again, no arm swing, shuffling, lurching gait. He has MSA. It's one of the bad brothers of Parkinson's, and he has a positive pull test. That was many years ago and many much grayer now. Freezing of his foot there, he got stuck. This is called a pull test for postural stability. If I didn't catch him, he would fall. So you should not do that unless you have good backup and that kind of thing. The next patient has what's called progressive supranuclear palsy. And they have a very characteristic deer in the headlights, kind of wide-eyed look at times, and a very characteristic speech. That's called spastic ataxic dysarthria. But she demonstrates on this video loss, pretty decent movements horizontally of her eyes, but her vertical gaze palsy is significant. Getting up, she can get up somewhat to the pen, but a little slow, but she can't get past midline or so looking down. They may have the applause sign where you tell them to clap 3 times and they keep clapping and don't stop. That's a frontal release sign. But we'll talk more about that in a second. And the next patient shows you how bad you can have what are called the Michael J. Fox movements dyskinesias in the setting of levodopa therapy. And this man was on levodopa with bad dyskinesias. He had lost a lot of weight, taking too much levodopa, too skinny a man, and should be more weight-based probably. But so lots of dyskinesia. It can get really bad. Now, if you have levodopa therapy and you have Parkinsonism and you have that kind of dyskinesia, it's almost always confirmatory of a diagnosis of Parkinson's disease. So levodopa dyskinesias are classic for Parkinson's. 95% chance at autopsy you have Parkinson's disease. These are some pictures of famous Parkinson's patients and some non-Parkinson's patients. So Janet Reno had Parkinson's disease. Gene Simmons had other things. And then the lead singer for Earth, Wind and Fire is there. African Americans do get affected with Parkinson's. Muhammad Ali had it, but I certainly don't see it as often in our clinics as Caucasian folks. And Hispanics may be a little more often than Caucasians, according to some data. Hitler had Parkinson's. You can Google it and find a video of him with a impressive resting tremor that was from the Smithsonian video series showing his Parkinsonism. Charles Schultz, who was the drawer, Snoopy, Pope John Paul, Michael J. Fox. Now, the next one is interesting. All of these ladies have now passed now that Betty White passed away, but the Golden Girls, Estelle Getty there in the red outfit, she actually had Parkinson's disease, and according to the reliable medical source, Entertainment Tonight, had developed dementia. And so it really points out that patients with Parkinson's can develop dementia over time, at least half the time in most series, but maybe 3/4 of the time they develop some cognitive impairment or more. The next guy is the most famous person that I know of with progressive supranuclear palsy, which we'll talk about in a minute. But remember this, you can't look up and down, you lose your vertical gaze, and you fall very early. Those are the classic features that help you differentiate PSP from Parkinson's disease. The bottom right.
Is there any truth to falling backwards versus falling forwards in PSP?
I would say with my experience, yeah, the more people fall backwards with PSP than they fall forward. And that's just from an experience over 20 years of seeing these patients. But Yeah, I think that's true, but you can fall any direction. And there's something about their pain threshold too. They don't have as much pain when they fall and break ribs and hurt stuff as other folks. They seem to have a different pain threshold. That's not been well studied, but it's interesting. Yasser Arafat also had Parkinson's disease. Salvador Dali did. Billy Graham was thought to have Parkinson's initially or have dementia, but I think he was eventually labeled with normal pressure hydrocephalus, which we'll talk more about in a minute. But it's a diagnosis that is difficult, and he got shunted and apparently improved. And then Robin Williams was apparently labeled with dementia with Lewy bodies. I don't know about that diagnosis in him when he's able to function on a movie set and act and memorize lines. So I don't know how true that was. So what are some of the important causes of Parkinsonism? I have way too many slides today. I think I didn't realize how long I'm going to talk, but you can save these for reference as well, the ones I don't get to. But Parkinson's disease is certainly the most common cause of Parkinsonism. Again, bradykinesia at least, plus other features like resting tremor on one side, cogwheel rigidity, and sometimes gait disturbance as the disease progresses in most patients. There's a literature out there that says that Alzheimer's disease patients actually develop Parkinsonism. I'm not a believer in the Rush data that has come out in the least, given that I've done Parkinson's for 20 years and I know the amount of Parkinsonism that's out there. But Alzheimer's is reported by some authors, one at Rush particularly, that indicates that there's significant Parkinsonism as rated by a Parkinson's rating scale, indicative of like moderate Parkinson's disease. I don't see that in practice doing Alzheimer's for 10 years. I don't buy it, but yeah, can they have Parkinsonism? They can. Essential tremor, folks with long-term standing ET can have Parkinsonism that develops over time, but most folks do not have idiopathic Parkinson's disease develop, but there is some literature that says they may be at higher risk of developing it in the long term. Most importantly, with today's therapies, drug and toxin-induced Parkinsonism is not that uncommon. There are a ton of people that are on dopamine-blocking antipsychotics, as well as Depakote, valproic acid, as well as Reglan, metoclopramide, those kind of medications that are used for gut function. And if you take something that blocks dopamine, you can develop Parkinsonism from it. And so we do see Depakote-induced Parkinsonism. There was a nice series by Stuart Factor at Emory regarding this topic. We can see Abilify, Geodone, all these antipsychotics that block dopamine cause Parkinsonism. The three that don't really cause Parkinsonism that are out there are quetiapine, clozapine, which no one really uses because of the blood monitoring required, and pimavanserin, the new kid on the block. The two guys in blue here are what Dr. Sethi, my old mentor, referred to as are the bad brothers of Parkinson's disease. Progressive supranuclear palsy, again, can't look up and down and fall very early are your clues. And then multiple system atrophy, which is usually either a cerebellar variant or a Parkinsonian variant. MSA has different features than typical Parkinson's disease. You may have a lot of orthostatic hypotension standing up, bottoming your blood pressure out very early. You may have sexual dysfunction that's out of character for your age. You may have stridor, where you're breathing at night and it sounds really, really like a really loud snore, but it's really your airway is tight and dystonic and things. And so, and you have Parkinsonism that doesn't respond much in either one of these conditions to levodopa. And then dementia with Lewy bodies is an art, probably it's a committee made criteria that are out there for the diagnosis that initially were not so hot. Again, 50%, I think, specific or sensitive. I forget which one it was, but some additional criteria has been helpful. It's a hard diagnosis to make, but I do see a lot of Parkinson's disease dementia as the disease progresses, and I follow patients in the long term. But dementia with Lewy bodies, I make an occasional diagnosis of that, but not a ton. Corticobasal syndrome, I'll show you a video of that in a second, talk about that. You got water on the brain. You hear that a lot from patients here in Georgia. they said my husband had water on the brain and they gave him a shunt. So that's NP, normal pressure-cephalus. And I think that is probably overdiagnosed. And at least half of patients that come to autopsy have primary dementias like Alzheimer's and other dementias. And then vascular Parkinsonism, we'll talk briefly about that. And actually psychogenic Parkinsonism. So whenever there's gain, there's disease. So the Camp Lejeune water situation, welding toxicity, there's huge litigation. And some of my colleagues that did expert work for the welding lawsuits and things found a lot of psychogenic Parkinsonism in the patients that were making the claims.
John, going back to normal pressure hydrocephalus for just 1 second, you said it's definitely, you said it's overdiagnosed. And then the other question is it as reversible as the literature once suggested?
So there's an older neurologist in Savannah that I know and I'm friends with named Dr. Hemphill. And I was chatting with him in his office one day. And he said, I said, what do you think of NPH? He goes, I don't think it hardly exists. And that's his experience. And he's in his late 60s or 70s. And I think a lot of people feel that way. Other neurologists like Neil Graff Radford at Mayo Clinic in Jacksonville seems to be a big believer. I haven't had a chance to talk to him about it, but and he does a good bit of shunting. I have not seen in my career very much impressive, sustained, long-term benefit from shunting, and it leads to more shunts having to be put in and things like that. So I don't make the diagnosis very often, very rarely. So yeah, difficult. And then there's an interesting story called about the frozen addicts that toxin-wise, they got a hold of a pyridine or heroin type manufactured drug. They were trying to make MPP, but they cooked it too hot in California in the late 70s, early 80s, and they made MPTP as a byproduct. And what does MPTP do? Well, it kills dopamine neurons in the brain. And so these folks that you see here in this picture showed up in the ER suddenly, Parkinsonian, and couldn't move because the toxin in the designer drug had killed their dopamine neurons. They responded to levodopa because it was a presynaptic dopamine process, but they had fluctuations and wearing off of the medication, the levodopa. And you can see the lady in the front there has dystonia of her hands in a wheelchair. And it's pretty rough what they went through. But you can find that story. Ever since that was discovered, MPTP has been used in animal models to generate Parkinsonian animals. This is corticobasal syndrome. And notice how apraxic and useless her right hand is.
I want you to take your left hand and show me how to throw a dart.
Not the best throwing of a dart with her left hand. Difficult to show even the left side has apraxia as well. But the right hand, look at it, it's just useless. She can't do much with it at all. So you wind up with a jerky, myoclonic, tremulous sometimes, but myoclonic looking, useless one limb. Alzheimer's disease can cause this. I've had a patient that had Alzheimer's that caused a corticobasal syndrome picture, but classically it's more of a tauopathy. But rapidly progressive condition, terrible, rough, die in 5 to 7 years or less. How about imaging? Can it help you in the differential diagnosis of Parkinsonism? It can. So the hummingbird sign is shown here. In the left upper picture there in the mid-sagittal MRI, look at the midbrain. Let's see if I can get do you see my cursor?
Yes.
Okay, good. So this is the midbrain right here, and below that is the pons, and then below that is the base of the bird. So you see the bird, right? The head, the belly, and the tail feathers. So the head of the bird's kind of big and juicy in this picture, and it has a short beak that's like not too thin. In patients with PSP, they'll get thinning of the midbrain, and you see the long beak on this other guy here that has PSP. You see the hummingbird sign sometimes, okay? And so that can be helpful in differential diagnosis of Parkinsonism. Another sign that you see sometimes is what's called the hot cross bun sign. And that's illustrated here in the bottom diagram with the hot cross bun. If you look them up on the web, you'll see what they look like. They look exactly like that, but with gliosis of the pons structure there with a cross going through it. And that happens in multiple system atrophy, cerebellar variant. And then vascular Parkinsonism with lots of little subcortical infarcts and chunks of brain missing in the basal ganglia structures, and the subcortical white matter as well can also lead to gait dysfunction. What is vascular Parkinsonism? Well, it's a problem where you have lower half Parkinsonism. You can't walk as well as you used to. You freeze, you get stuck, but your uppers aren't too bad. You can do finger taps and other things like that pretty well. Sometimes it responds to levodopa, sometimes it doesn't. How about DAT scan? How's that useful? DAT scan is a radioligand called ioflupane, which has radioactive iodine on it. And if you have a presynaptic Parkinsonian process where you're losing dopamine neurons, and you use it to try to identify dopamine deficits in a patient, it binds this green guy here, the dopamine transporter on the presynaptic neuron. So as those neurons die with Parkinson's disease, PSP, MSA, all these other conditions, even dementia with Lewy bodies, the number of targets there for the dopamine transporter that the ioflupane binds to are reduced. So you lose that signal in the brain. This is what it looks like. The head of the caudate nucleus is here on this image, and this axial MRI image here, and the putamen goes right here. And that's what you're seeing in this structure. It looks like a comma. And patients with Parkinson's disease and its cousins, so PSP, MSA, Parkinson's, corticobasal, even vascular Parkinson's can have loss of dopamine in their brain and have the loss of the tail end of the comma is classic. So notice the tail end of the comma is more preserved on the right part of the brain here and less preserved on the left part of the brain. So this patient with abnormal type 1 imaging would expect to see right-sided Parkinsonism more than left. And then as the disease advances, you lose more signal in the putamen, and you eventually even lose more signal in the caudate head there that's illustrated. There's water on the brain, NPH, wacky, wobbly, and wet. Okay, so patients that have big ventricles often may see a neurosurgeon and get shunted with or without full testing. But wacky means you have cognitive changes that happen. Often with cognitive changes, it may be too late to shunt these people. You want to do it early when they're wobbly and wet, if you can, where they're having urinary incontinence, and a magnetic gait is what's classic. I look for the definition in the literature of what magnetic gait means, and it's all over the place in all these papers that I've ever read. So the diagnostic accuracy in Parkinson's is lowest in early Parkinson's disease. A study that was done by Charles Adler, a famous movement disorder neurologist at Mayo, Arizona, showed that in patients that were not so sure exactly what someone has Parkinson's-wise, that even a movement disorder specialist may be wrong half the time about the diagnosis in an early patient. If you have a nice resting tremor on one side and slowness on that side, and they're not on any drugs that cause Parkinsonism, you've got Parkinson's to prove it otherwise, and that helps you to have a resting tremor. Pathologists, as always, are the best diagnosticians, just a little too late. But movement disorder specialists and neurologists hopefully are pretty good at it. Primary care, in some situations, it depends on the primary care physician. Some rock at it and are good as diagnosticians as a movement disorder specialist I've met. And then others, not so much. They can't really discern or clearly whether it's a Parkinsonian tremor or an essential tremor, more with action. So, but it's certainly more difficult with akinetic rigid and atypical Parkinsonism, and accuracy in diagnosis improves over time. Again, dyskinesias with levodopa are very helpful. So loss of dopamine neurons in the substantia nigra is classic. You see in the Parkinson's disease patient's brain, the loss that brown dark stripe there, the pigmented neurons, you can see the dropout histologically. And then the neurons have Lewy bodies in them. That's the reddish thing on the bottom right that has the eosinophilic core. Let's see if I can get a cursor. There it is. The eosinophilic core here, surrounded by a white halo inside of a pigmented dopamine neuron. And it's a slowly progressive disorder. Patients don't show up to your clinic until they've lost half their dopamine neurons and maybe 70% of the dopamine. And Lewy bodies are the classic pathological hallmark of Parkinson's. Loss of those dopamine neurons leads to abnormal function of the basal ganglia movement pathways with dysfunctional motor control. And essentially, when you lose the dopamine regulation of the system, you have over inhibition of movement. That's what Parkinsonism is too little movement. Other causes of movement disorders may cause chorea, like Huntington's disease, where you have too much movement, but Parkinsonism is loss of movement where you have too little movement. Brock proposed this hypothesis of how Parkinson starts, olfactory bulb and the brainstem, the medulla oblongata, and then spreads rostrally up into the brain from there and causes problems in numerous different structures. But according to his staging, it's not till stage 3 till it hits the state of substantia nigra, where the dopamine neurons regulating movement are. We don't know the cause of Parkinson's disease yet, but there's probably links between genes, multiple different genes, multiple risk factor genes, and environment, pesticides, rural living, well water, et cetera, leading to clumping of proteins, mitochondrial dysfunction, oxidative stress, neuroinflammation, all kinds of troubles, and apoptosis and cell death. The two most common causes genetically of Parkinson's worldwide are glucose cerebrositis mutations, which also cause Gaucher's disease, and then LRRK2, leucine-rich repeat kinase 2 mutations, which can occur as well. And then what are the treatment options in Parkinson's disease? There's watch and wait. My buddy Dave just coming in. And you can also consider clinical trials. And then medication-wise, levodopa is certainly the standard of therapy, the gold standard. Deep brain stimulation and focused ultrasound have emerged as important surgical options for patients and can make a big improvement in quality of life. And then rehabilitation therapies are real important as well. There's a thing called the Lee Silverman voice therapy technique, which works with voice volume called loud. And there's a big therapy technique, which works with amplitude-based movements. Exercise regimens are important for patients, rock steady boxing, tandem biking, and then there's all kinds of complementary therapies that can be used as well. Few slides, I'm done. Mucuna pruriens is also known as velvet bean or cow itch plant. Ironically, in Indian Ayurvedic medicine, it had been used for years to treat a condition called Campavada. And Campavada in the Sanskrit was a condition that sounded a hell of a lot like Parkinson's disease, with slowness, stiffness, hunched posture, things like that. Why is that ironic? Well, in the 1930s, they found that Mucuna pruriens has levodopa in it. And this Ayurvedic remedy actually was shown in a clinical trial by Katzenschlager years ago in 2004 to be better than a pill form of levodopa to treat fluctuations of Parkinson's patients. So replacing dopamine is the key. Inhibiting enzymes which degrade dopamine or levodopa is the key to treat Parkinson's disease. And these medications work at different spots in the brain system. Some work outside the blood-brain barrier, get more levodopa into the brain. I can't give someone straight up dopamine to treat their Parkinson's disease because it won't cross the blood-brain barrier. I have to give them levodopa. It's transported across the endothelium into the brain, and then the substantia nigra neurons convert it to dopamine to treat that. The oddballs out include istradefylline, which helps with wearing off of medications. This medication is fairly recently approved, and it helps by a novel mechanism. And the anticholinergic drugs like benztropine and trixaphenidyl can help tremor significantly. So in summary, Parkinson's is a complex and extensive differential diagnosis. It's very difficult for even me on many days. And always look for offending medications. So dopamine blocking agents, the antipsychotics, Reglan, metoclopramide, even Phenergan and Compazine can block dopamine, and then Depakote. Even lithium can cause Parkinsonism too. Exercise should be encouraged in all patients to the degree they can do it. Levodopa therapy is the mainstay of therapy. Paramedical therapies like PTOT speech are very helpful and have good data behind them. And if someone has a sustained response to levodopa, it's consistent with Parkinson's disease. Atypical Parkinsonism or Parkinson's plus conditions are much harder to live with. And again, the bad brothers are MSA and PSP, and more debilitating and progressive to live with. And that's it.
Hey, Dr. Morgan, thanks so much. That was awesome. The videos
you.
were particularly helpful, so we really appreciate you joining us today.
Thank you.
Lori Beth put up the QR code and or the link is in the chat. And if you would please take the time to just give us some feedback about today's presentation. And we hope that you will join us monthly. So Dr. Morgan, thanks again.
Thank you.
Deeply appreciative. Thanks again.
Okay. Y'all have a good day. All right. Bye-bye.